bonic trauma. Very much competent as numbers of papers I have submitted to the Bangladesh Rheumatology Society for presentation. Literally, it was dozens. So among those, an expert jury board scrutinized and finally selected 4 papers. Before going to invite the first presenter, I have to say, due to time constraint, each presenter is requested to complete his or her presentation within 7 minutes. So let's start with our first speaker, Dr. Alamgir Mustaq Ahmad.
প্রেজেন্টেশন কি নাম ছিল? আলমগীর। আলমগীর। এখানে ফ্রি পেপার নাম্বার এটাই তো দিছে শুধু আমাকে প্রেজেন্টেশন। আলমগীর নামকে আগে আগে কি দিছিলেন স্যার? আপনি দিয়ে আসলাম যে আলমগীর নাম এটা আপনার কাছে?
कॉपी करें।
Okay. May I draw the attention of the presenters because there will be many presentations and hardly you will get any time. So may I request you to conclude the presentation with a single sentence about your key finding. Single sentence, please.
Assalamu alaikum. Honorable Chairperson, Professor Abul Kalam Azad, respected moderator and learned audience, welcome to this session. This is about systemic lupus erythematosus and its diagnostic delay and determining factors of the disease. You know, SLE is a autoimmune, multi-system autoimmune disease, mostly occur in female at their childbearing age, and prevalence ranging from 20 to 150 per 1 lakh population. But the incidence is gradually increasing over days due to advanced diagnostic facilities. And the 1 to 2 years delay is usual even in developed countries. And there are several factors for this delay. Likely, the symptoms usually develop abruptly or it may come one after another with time. And early presenting features may be variable and non-specific. And in respect of age and sex, presentation may have various form and in various severity. And there might be some other factors, lack of interest, confidence, and competency of physician regarding musculoskeletal system examination, lack of healthcare facilities, and to find out the diagnostic delay and factors behind it. It was a cross-sectional study done at Lupus Clinic of Bangabandhu Sheikh Mujib Medical University, and 85 patients were enrolled who were diagnosed as per revised ACR criteria 1997. And data were collected through interviewing with a semi-structured questionnaire containing about 9 outcome variables. These are the variables including particulars of the patient, initial symptoms, their education and socioeconomic status, availability of healthcare facilities, health-seeking attitude of the patient, and referral attitude of the healthcare provider. And this is the age distribution, and most of the patients were young adult in our study. This is the appearance of symptoms at different periods of time. Symptoms appear, organ involvement increased with the passage of time in our series. And most commonly appeared symptoms was musculoskeletal symptoms, that is joint pain, arthritis, and then constituent symptoms, mucocutaneous involvement, and about in 40% cases, was also involved. This slide reflecting the delay to the healthcare delay in first visit to the healthcare providers in respect of sex after appearance of initial symptoms. Here we see that men and children see the early consultancy, and most patient consultancy to the doctor and consultant. And this is showing the referral attitude for provider. Only referred to another physician or other doctor for further evaluation and for final diagnosis. And presently, this is a tool in our healthcare system. This is very important slide. Here we see the missed or ignored symptoms. Ignored symptoms during evaluation of the patient by the physician. And mostly joint pain, ulceration, fever, evaluation are missed or ignored during the evaluation of patient by the physician, and that's ultimately lead to the delayed diagnosis. In our series, the mean about 12.3 plus minus 13.9 months. And in respect of age and sex, if we see the delay, here male and children got the earlier diagnosis. And this study result is not actually consistent with other study. It may be our parents are more cautious about their offspring's health, and our female gives more importance to the to their bread and butter winner of the family. And this slide showing the urban population and who are solvent and who have easy access to the healthcare facilities got the early diagnosis. And this is about the comparison of diagnostic delay in different subgroups of patient by the health-seeking attitude of the patient. Here, who got the early consultancy to the qualified physician got the early diagnosis. This is the comparison of diagnostic delay in different groups of patient by the presence or absence of various initial symptoms. In this series, who had oral ulceration, alopecia, and lupus nephritis received early diagnosis. And this was statistically significant. And this is another slide, is very important slide. Those patients who have joint pain and fever at their initial stage of presentation got the delayed diagnosis. It may be due to in SLE, joint pain may be mild, or sometimes, and there is no deformity, and joint pain is also present in many other rheumatic and non-rheumatic disease. So in this case, joint pain is delayed. With joint pain's diagnosis is delayed. Now, from our series, the statistically significant factors for early diagnosis was presence of oral ulceration, alopecia, renal involvement, and earlier consultancy to the competent physician. And significant factors for delayed diagnosis was presence of arthralgia or arthritis at their initial presentation. And what may be the consequence of delayed diagnosis? Like the increased rate of higher disease activity, flare, hospitalization, hospital cost, and disease-related organ damage, fatigue, and poor quality of life. Now, according to our series, how we can prevent the diagnostic delay? And it's required high index of suspicion, especially for patient with non-specific features like arthralgia, arthritis, and as well as alopecia and careful searching of alopecia and oral ulceration. Improving healthcare facilities, developing structured referral system, improving patient awareness in health-seeking behavior, ensuring early consultancy irrespective of age and sex, and proper musculoskeletal training of the physician. Thank you all for patience hearing, and I would like to thank the Bangladesh Rheumatology Society to give me the opportunity to be here, and for during conduction of the study, who helped me a lot, Professor Nazrul Islam, and Professor Syed Adikul Haq, and Professor Minhaj Rahim Chaudhary, and Dr. Sabrina Yasmin, Dr. Imtiaz Sultan, who helped me also in data collection. Thank you all again.
Thank you, Dr. Alamgir Mustaq Ahmed. May I request the second presenter and the other presenters also to cut short their presentations and to limit their presentations to be accomplished within 7 minutes. So may I request Dr. Tanmoy Biswas to come up here on the dais to present his presentation. Dr. Tanmoy Biswas.
Time maintain korun amra. Please give a ring.
পড়ে যাচ্ছে এটা কি Hello. Honorable Chairperson, distinguished guest, and learned audience. The topic for today's presentation is socio-demographic profile and initial presentation of systemic lupus erythematosus, an experience from a tertiary care hospital. I am Dr. Tanmoy Biswas, the presenting author, and here are the list of authors of this study. Here are the contents. I will go through them one by one. SLE, as you know it, it is an autoimmune condition and that affects multiple systems of our body. But most commonly, skin and joints are affected. Develops between 14 to 45 years with a female to male ratio 9:1. The presentation of the disease have extensive geographical variation. So our study aimed to identify the socio-demographic profile and initial clinical presentation of SLE patients. Particularly, we wanted to detect socio-demographic profile, initial clinical presentation in the first 3 months, time required for diagnosis from the symptom onset, associated social factors, social issues, and other social stigmatas. It was a cross-sectional observational study done in Green Life Medical College Hospital and Green Life Center for Rheumatic Care and Research,
from January 2019 to December 2021 for around 2 years. We included the patient who came for follow-up and who were newly diagnosed and who fulfilled SLICC criteria 2012. We excluded overlap syndrome and mixed connective tissue disorders. Preformed questionnaires were distributed among the patients. Then data were collected through face-to-face interview and reviewing previous medical records. Our sample size reached to 252. Data analysis then done by SPSS version 22. We particularly looked at the percentage and frequencies. In this study, female-to-male ratio was 11.6:1, and mean age for all were 29.5 years. Most of the patients, 48.4% were homemaker, 69% came from urban population, none of them were a smoker, and 62% were married. 26.1% patients were graduate, and 42.8% patients came from low to middle income family with a monthly family income of 10 to 30,000 BDT per month. Age at the time of diagnosis. The most common age was between 18 to 30 years for most of the patients, with a frequency rate of 46.03%. The initial clinical presentation in the first 3 months. Most of the patients presented with the non-specific features. Fatigue was the most common with 82%, followed by arthalgia and fever. SLE specific presentations, for example, facial rash was frequent in 60%, non-facial body rash in 48.4%, alopecia 45%, and mouth ulcer 65%, etc. Regarding the systemic involvement, blood disorder was frequent in 56% patients of our study. Among them, anemia was the most prevalent with 54%. 47% patients had lupus nephritis. Among them, proteinuria was the most common presentation. 31% patients had the CNS involvement, and 22% patients had the polyserositis. Among them, among the total population of a study, 15% had the pleural effusion, and some of them had severe abdominal pain. This picture portrays the time delay in the diagnosis. Time required for diagnosis from the initial presentation was less than 6 months for 43% patients. That means majority of the patients required more than 6 months of diagnosis. The time required from diagnosis from the initial presentation ranged from 1 week to 15 years, with a mean time delay of 1.5 years around. We have also addressed some social issues. 50% patients told their family members are scared about lupus, and 17.4% patients' family thought them as load or burden on them. Here are the points to be discussed here. In this study, majority came from the urban areas because the study center was a private tertiary care hospital. They came from low to middle income families. Fever, fatigue, musculoskeletal symptoms are the most common initial presentation. Male-female ratio, initial musculoskeletal presentation, frequency of blood disorders, and lupus nephritis. These are consistent with the previous studies from the literature. A significant number of patients had delay in diagnosis. Literature suggests delaying diagnosis adversely affect clinical outcome. Around 18% family of SLE patients thought them as a burden, a matter to be addressed. The main strength of this study was it had a large sample size and we also addressed the social issues. And the main limitation was it was a single center study in a private tertiary care hospital. So we recommend large nationwide multi-center study, which is necessary to detail the socio-demographic factors, presentation, and social issues. This would help in the future about the policy making for the SLE patients. In conclusion, SLE often presents non-specifically. So high index of suspicion is essential, especially for young female patients, for early diagnosis. because delay in diagnosis cause high mortality and morbidity. Female patients presenting with non-specific fatigue, fever, or arthalgia should be investigated. Here are the references. And we acknowledge Department of Medicine, Green Life Medical College, and the principal investigator, Professor Roshanara Shopna Madam. Thank you, audience, for your kind attention.
Thank you, Dr. Tanmoy Bishwas, for very brief, nice, and timely presentation. May I request our third presenter, Dr. S.K. Zakaria bin Said. So, Dr. S.K. Zakaria bin Said, please come up here and start your talk.
মাউস আসতেছে না এখানে হ্যাঁ সরি হচ্ছে মাউসটা আসতেছিল না
It's not responding.
পেন ড্রাইভে আছে this one আমার এটা লাগবে
Assalamu alaikum. Good afternoon to all of my respected teachers and learned audience. I am Dr. S.K. Zakaria bin Said. Would like to present our research work in front of your presence, and I feel privileged here to present my work. Here is our research team. I'm really thankful and grateful to Professor M.D. Mujibur Rahman, Dr. M.D. Monirujjaman for their continuous support regarding the research work. Infections are common, costly, and morbid complication for patients with rheumatic diseases. Disease activity, comorbidity, and immunosuppressive medications can contribute to infection risk. Particular concern about infection, knowledge of potential risk not only influence the treatment decision, but also important for monitoring and management of rheumatic diseases. Reporting of infection among rheumatological diseases is very limited in our country. We thought this is one of the gray area where we can work to evaluate the pattern of infection and find out the factors responsible for infection. Methods. Our study design was retrospective, conducted at Rheumatology Clinic of Dhaka Medical College Hospital using the data registry software system from January 2019 to December 2021. Here, all the diagnosed cases of different rheumatological disease who are on immunosuppressive medication with documented infection were included. Our objective were to evaluate the pattern of infection to find out factors associated with infection. Ethical permission was taken from ERC of Dhaka Medical College Hospital. Here, all the investigators do not have any conflict of interest. Statistical analysis. All data were analyzed by Stata 15 to compare the variables with the infection. For categorical variable, chi-square test was performed. For continuous variable, independent student t-test were performed. For factor analysis, multivariate regression analysis was done. For association of medication with infection, ordinal regression model was used. result. This is the first table showing the demographic, clinical, and medication history of our enrolled patients. Mean age around 33, most of them were female. 44% had low BMI, that is less than 18.5 kg per square meter of body surface area. Hypertension and diabetes were the most common comorbidities. Most of our cases were SLE, lupus nephritis, rheumatoid arthritis, spondyloarthropathies, and other connective tissue diseases like systemic sclerosis, GPA, Takayasu, MCT, and overlap syndrome with post-cheek chronic inflammatory rheumatism. Most common prescribed medication, conventional synthetic DMARD, that is methotrexate, hydroxychloroquine, sulfasalazine, along with prednisolone, some immunomodulator, and biologicals like tofacitinib, adalimumab, and rituximab. This table is really important because where we can find out easily 4 groups of patients are suffering varieties of infection. That is, patients who are diagnosed as lupus nephritis, SLE, rheumatoid arthritis, and spondyloarthropathy. There are varieties of infection, including the COVID-19. This is the pie chart that is showing the frequency and pattern of infection. Most common infection was COVID-19, as our study time was during the COVID also, followed by urinary tract infection, fungal infection, herpes zoster, pulmonary TB, latent TB, pneumonia, and sepsis. This is the simple bar diagram showing 2 important information to us, that whenever a patient with rheumatic disease started with conventional synthetic DMARD is associated with low rate of infection, but when it is adjunct to steroid or other immunomodulator, then the infection gets mounted up. This is the baseline laboratory characteristics of enrolled patients, where you can easily find it out that most of them had anemia, high inflammatory marker, some had proteinuria, hypoalbuminemia, hypovitaminosis D, and some of them are tuberculin skin test positive. And this is the cornerstone of our study work. That is the factors that is associated with infection. That is underweight, anemia, hypoalbuminemia, hypovitaminosis D, high blood sugar, and inadequate counseling regarding the side effect of steroid. Some medication like cyclophosphamide, mycophenolate mofetil, and prednisolone more than 10 milligram per day for at least 3 months or more is strongly associated with infection. Here is the summary I have already talked to you while presenting the table and chart. Still, the backbone of current maintenance therapy for rheumatological diseases continues with the DMARD. Sulfasalazine, hydroxychloroquine, methotrexate have best safety profile, low rate of infection. However, biological agents and prednisolone more than 10 milligram per day are associated with opportunistic infection, pulmonary TB, and fungal infection. So we can have some opinion that underweight, anemia, hypoalbuminemia, high blood sugar, hypovitaminosis D, inadequate counseling about steroid side effect were associated with infection among the patients with the rheumatic disease. Immunomodulator like cyclophosphamide, MMF, tofacitinib, prednisolone more than 10 milligram per day for at least 3 months were associated with opportunistic infection, pulmonary TB, latent TB. And conventional DMARD were not associated with infection. Limitation. It is a single center retrospective study, small sample size, did not assess disease activity in some patient at the time of infection because in that time COVID pandemic was going on. Acknowledgement. Special thanks to all of my colleagues and nursing staff for their continuous support. I'm really grateful to all of my patients because their information led us here to share our experience with you. Thank you.
Thank you, Dr. S.K. Zakaria bin Said. Our last presenter is Dr. Shongita Bonik Prabha. May I request her to come up here on the dais? Dr. Shongita Bonik Prabha.
আপনার ইয়ারটার নাম কি ছিল যে
পেপার ডক্টর সংহিতা। আমি নাহলে এই যে
আমি রাখছি
Assalamu alaikum and a very good afternoon to you all. I'm Dr. Shangita, intern doctor from Sir Solimullah Medical College and Mitford Hospital. And I'm very much honored to have the opportunity to present in front of all of you. Today, I will be presenting a case report titled An Unusual Presentation of Cerebral Vasculitis in a 21-year-old SLE patient. Systemic lupus erythematosus, or SLE, is a chronic autoimmune disease that can manifest in a myriad of presentations. Though its diagnosis relies on ACR criteria 2019, its manifestations on various systems often pose a challenge for the clinicians. Among various system involvement, central nervous system involvement occupies up to 60% of the patients. Cerebral hemorrhage is reported in 0.4 to 7% of cases and is mainly caused by various iatrogenic factors. For example, arterial hypertension, thrombocytopenia, anticoagulation, etc. So today, we are going to present an exemplary case along with its dramatic progression and review the literature on this atypical entity. My patient, a 21-year-old female, presented with multiple convulsive episodes for one day. She also complained of recurrent multiple oral ulcers and facial rashes for about 6 months. The convulsions were generalized tonic-clonic seizure in nature, which persisted for about 1 minute with loss of consciousness, eyes rolling back, jerky movements of the whole body, and inability to respond to verbal stimulus. On query, the patient gave us no history of fever, headache, vomiting, or any other associated neurological symptoms. She also never experienced convulsions before on her lifetime. When the facial rash was noticed, it was seen that the rash was erythematous, photosensitive, raised, tender, did not disappear on compression, and spared the nasolabial fold. There were also multiple mucocutaneous ulcers from which spontaneous bleeding occurred for the last 5 days of admission. After admitting the patient, we started to take our detailed history. We saw that the patient had no previous established diagnosis, but we still took a detailed history to exclude various diseases. We asked the patient particularly if she had any complaints regarding arthralgia, leg pain or calf tenderness, paresis or paralysis of any half part of the body. But the patient's response was negative. There was also no skin tightening, discoloration of finger skin on cold exposure, dry eye or oral or vaginal ulcer. She also didn't have any history of frothy urine, muscle weakness, or any swallowing difficulty. Family history was also negative for the aforementioned diseases or symptoms. When asked about her obstetric history, we found out that she had a history of spontaneous fetal loss on first trimester on her only pregnancy. She was also on oral contraceptive pills for the last 5 years. After query, we started our examination. On general examination, we saw that the patient was anemic with other vital signs within normal limit. She had no jaundice, cyanosis, clubbing, chylomicria, leukonychia, dehydration, edema, lymphadenopathy, or thyroid swelling. There were also no other rashes or any other parts of the body. On neurological examination, the GCS score of our patient was found 13 due to lack of responding spontaneously, disorientation of time, place, person, confusion, inability to follow command. But there was no focal loss. Fundoscopy and thorough examination of the other system also appeared to be normal. After complete evaluation of the patient, we found out that the positive findings in our patients were anemia, facial erythematous butterfly rash, photosensitivity, mucocutaneous oral ulcers, non-scarring alopecia. With all the history and examinations in our hand, we concluded on two differential diagnoses. Those were cerebral vasculitis due to SLE and intracranial space occupying lesion or EXOL. As the patient got admitted in our hospital with her chief complaint as convulsion, we suggested an urgent MRI. The MRI of our patient showed that hemorrhagic infarcts involving both capsuloganglionic and deep white matter of the frontal lobes. We also did routine biochemical tests, which showed our patient was anemic, pancytopenia was there with raised ESR, and the PVF showed normocytic normochromic anemia. In urine analysis, we found trace amount of urine. In the immunological profile, the patient's report, ANA report and anti-dsDNA report came back strongly positive, with antiphospholipid IgG and antiphospholipid IgM being negative. In ENA profile, anti-RNP and anti-Rho antibody was positive. In the complement, we also see decreased value of C3 and C4. Renal function of our patient was normal with serum creatinine level at 0.83 milligram per deciliter, and the blood and urine culture showed no growth. With a notion formed on examination findings and various investigations report, we decided to utilize the diagnostic criteria of SLE, which is ACR criteria 2019. And on ACR criteria, usually the score more than 10 is diagnostic of SLE, in which our patient had a score of 21, with thrombocytopenia, seizure, oral ulcer, low C3, C4, and anti-dsDNA. After the ACR score being positive, we applied SLEDI score to observe the disease activity of our patient, because as high the disease activity, higher the risk of vasculitis. And the SLEDI score of our patient came as 48, which referred to very high activity. So with all this, we reached our final destination, the confirmatory diagnosis, SLE with cerebral vasculitis. In our treatment process, it was conducted in two steps, hospital management and on discharge. For immediate management of convulsions, we use injection levetiracetam and injection fosfenetuen in our hospital. And for the management of SLE, we used pulse methylprednisolone therapy, which was followed by oral prednisolone, tablet MMF, and tablet hydroxychloroquine. The patient was improved drastically within 7 days. Then on discharge, we prescribed our patient tablet prednisolone 40 mg per day, tablet MMF 2000 mg per day, and tablet hydroxychloroquine 300 mg per day. The patient was advised to come for a follow-up after 1 month. And after 1 month, when the patient came, we saw the patient was clinically improved with no convulsion, oral ulcer, facial rash, or any other presenting symptoms. We ordered an MRA of brain, which showed normal MRA findings, which referred to us that the patient was on recovery following our treatment. At the end, I would like to say that vasculitis can have a heterogeneous presentation in SLE, but no gold standard diagnostic criteria is present. However, a combination of clinical, serological, and imaging data usually have sufficient diagnostic value and can be used. And in our case, we try to do the same. With all, here I would like to conclude my presentation. But before that, I would like to thank my mentor, Associate Professor Dr. Amirujjaman Suman sir, for his guidance and help. And thank you, dear audience, for patience hearing. Thank you.
Thank you, Dr. Sangeeta, for a nice presentation. This time, we are waiting for cutting-edge comments from our two chairpersons. First one from Professor M. Mustafa Jaman, the eminent researcher right now of Bangladesh. And next, an astute clinician and mentor, Professor Abul Kalam Azad sir.
Thank you very much. And by Drs. Alamgir, Tanmagaria, and Sangeeta. It was very clear from the age of the presenters that they are very young. They are at the beginning of their career. But the presentation they made sounded like they have already earned a lot of skill to make a good presentation. Their studies were excellent, wonderful, and all those could be utilized for clinical practice. And if adequate mentoring is done by their mentors, respective mentors. I believe these studies can be published soon in the journals, and only then the continuity of their work will remain. So I would like to request them to do that without any further delay. Coming to specific studies, the first one was on the diagnostic delay of SLE. And it is really heartening to see the first diagnosis or confirmed diagnosis is done after 10 years. These are being delayed because either they did not go to appropriate doctor, or the doctors were appropriate but they ignored the diagnosis or the clinical characteristics of the point. One interesting finding here is presence of joint pain delays the diagnosis. I understood it like this. Once they have arthralgia or arthritis, people start considering them as a case of rheumatoid arthritis or something else. So the first impression of SLE doesn't come. That might have hindered the initiation of treatment at the beginning. The second one was the initial presentation of SLE also. The patients had a mean age of 30 years. And here, the delay was 1.5 years on average. So this is completely different from the first one, 1.5 years versus 10 years. So we need to see the data in detail, what makes this difference. And the classical presentations were fever, fatigue, and other musculoskeletal symptoms. Once we have this, we should reconsider our clinical decision that the patient might have SLE. Dr. Zakaria's study was on factors related to infection. Those who had rheumatic disorders. He has clearly mentioned that those who received hydroxychloroquine, cyclophosphamide, along with steroid, and that increases the possibility of urinary tract infection. So we need to be cautious about the doses and the drug we prescribe for our drugs. The final one is from Dr. Sangeeta. That's a case report, and because the patient had unusual presentation that deserves to be published for attention of the concerned practitioners of the country. So the differential diagnosis they have given might be true, but I would like to leave that part to my learned co-chair, because I am not a clinician, so I am not stepping into that. Thank you.
Thank you, sir. Thanks to all. Good evening and good afternoon. I am highly privileged to be here. Thanks to all the presenters. First to the Dr. Alamgir Mustaq Ahmed, and he has presented nicely. But I have some query about this thing. He has mentioned that it is better to present in the median mode. It is better to present in this way. I think so. And there is a delay when the patient is presenting with the arthralgia. And why arthralgia this is the cause of delayed presentation? It should be evaluated. Is there any relation of the take of the steroid, oral prednisolone, the traditional medicine intake, or something else? And when patients are presented with the skin manifestation, patients are diagnosed early. So this can be addressed in your presentation. This can be evaluated, and this will be in that case it is a very good study. And second presentation regarding the Mr. Tanmoy Vishwas, this is more or less same type of case. You mentioned that they have done a study with the help of the SPSS. So there is no need of SPSS because it is presented only in frequency table. So it should be presented in a frequency table, and this is more than enough. There's no correlation with the SPSS version 22. Okay, his presentation is very good. This is young man, overall is very good. And now this presentation is the Biologists and Zakaria. This is excellent presentation. It is excellent good of work. You mentioned that when each patient was taking the troposidinib, there is a correlation, there is in 3 months later on, there is every chance of the tuberculosis. But in this your study, it is better to address the patient's quantiferon goals are done or not. If it is common position that the patient is not taking the quantiferon goals positive or negative, in that case, TB can happen after 3 months. But you can address this quantiferon is negative and TB was positive. This can be a good issue. You can address this thing. And if you can show there is a correlation with the neutrophil count, if there's ANC and infection, this it can be also very good prediction. Regarding the Shangita Bonik Proma, this is your excellent case report, but you have mentioned that this anti-Rho, that's NTSS-A, SSB was positive. So this can be a case of overlap. There is every chance of overlap. And this case should be followed up. Because definitely SLE may be a possibility. There is a vasculitis. There is no issue. There is seen as vasculitis, but this case should be followed up. And there may be an alternative diagnosis, and there may be a co-diagnosis may be present. Thank you, everyone. Thanks you.
Thank you, dear speakers and chairpersons and moderator. Now this is time for memento handover. Now I'd like to request Professor Dr. Mohammad Nazrul Islam. Professor Dr. Mohammad Nazrul Islam, Secretary General APLAR, please come up on the dais and hand over the memento to our honorable speakers, chairpersons, and moderator. First of all, our speaker, Alongir Mustaq Ahmed, please. Dr. Tanmoy Bishwash, Dr. S.K. Jakaria bin Said, Dr. Shangita Bonik Proma. All four, please come up on the dais. Next, Tanmoy. He is son of our Professor Sunil Kumar Bishwash. S.K. Jakaria bin Said. Shangita Bonik Proma. Shangita, please. Next for chairperson, first Dr. Professor Abul Kalam Azad. Azad sir, একটু স্যার আপনি ধরেন হ্যাঁ নেক্সট প্রফেসর এম মোস্তফা জামান Last of all, I like to request both the chairpersons to hand over memento to our moderator. Chairperson, you can also. Oh, ওটা আমি হাতে দিই হ্যাঁ নাও নাও Thank you. This is the last session, most attractive session. We are waiting for this particular lecture from our President, Professor Soyed Atikul Haq. This program session will be chaired by Professor Dr. Robed Amin and Professor Sharbani Sengupta, and will be moderated by Dr. Jiaul Haidar. This is very important lecture. Please keep silence, and I think we all enjoy this session. Now I'd like to request both the chairpersons, speaker and moderator to come up on the dais. Sir, chole আসেন, sir.
এটা কি ঠিক হলো?
After the end of this session, there is a lottery with attractive prize. You see the lottery gifts here: television, fridge, laptop, and please preserve your token. Thank you all. Another announcement, please prepare yourself, all the poster presenter. Our jury board is going to the site of poster presentation. Please present yourself, please present your poster to our jury board. Thank you, sir.
Assalamu alaikum. Welcome to this last session, scientific session of 14th Scientific Conference of Bangladesh Rheumatology Society. Actually, we are eagerly waiting for this session because of the speaker of this session, because the speaker is very much popular for his speech, and he is the mentor of the rheumatologist of Bangladesh. And I feel proud to introduce to this speaker in front of you, Professor Soyed Atikul Haq sir. He was the former professor of rheumatology, Bangabandhu Sahib Medical University, and Epler. Actually, he is the founder of rheumatology in Bangladesh. He started rheumatology clinic in Bangladesh in 1991, and he participated in forming Bangladesh Rheumatology Society in 1997. Now he is the president of Bangladesh Rheumatology Society. He founded COPCOD study group in 2000 in Bangladesh. He received fellowship from Royal College of Physicians of Edinburgh in 2002-3 and international fellowship from American College of Rheumatology in 2005. Professor Hawk's area of academic interest in epidemiology of rheumatic disorder, osteoarthritis, SLE. He has 181 publications out of 101 published in international journal, and among them 43 published in peer-reviewed journal, and few of them have high impact cited index. He was awarded gold medal by Bangladesh Academy of Science for the contribution to the advancement of science in the country in 1997. He has served Epler in capacities of Epler coordinator, vice president, and treasurer. Now, I am requesting Sir to deliver his today's speech on vasculitis associated with infection, drugs, and malignancy. Sir, please.
Okay, thank you for your detailed introduction. Respected chairpersons and dear colleagues, I thank the organizers to give me the opportunity of talking before this learned audience, and at the same time giving the responsibility to me to bat as the last batsman of this one-day series. So my topic is vasculitis, drugs, cancers, and infections. It is, in fact, vasculitis, as per Chapel Hill Consensus Conference categories, you can see this vasculitis associated with probable etiology. This is a distinct category. And under this category, you can see hepatitis C, hepatitis B, syphilis associated. Though the basic premise of Chapel Hill was to avoid, recommendation or categorization of infection-associated vasculitis, finally, the participants of the CHCC could not avoid it. So there are a few infections. Then drug-associated immune complex vasculitis, drug-associated, ANCA-associated vasculitis, and cancer-associated vasculitis. So I can say that actually I have been entrusted to speak on this category of CHCC categories, vasculitis associated with probable etiology. So you can see actually, though Shaheen told me that, sir, it will be a very simple task. You already have a lecture prepared on infectious vasculitis. Just you'll add 2 or 3 slides for cancer and drugs. But while, attempting to do this, I found that I had to put the Jenny inside a small bottle. So first I shall go to drug-associated vasculitis. The presentations of drug-associated vasculitis are palpable purpura, and this is the commonest presentation. And it is usually not associated with features of vasculitis in other organs and no systemic manifestation. So we can say it presents somewhat like single organ vasculitis, that is another category, CHCC category. And also some of the patients may present with joint pain, myalgia, arthritis. And if the offender drug is not quickly withdrawn, then it may finally present with renal manifestations like hematuria, proteinuria, sometimes end-stage kidney disease, pulmonary manifestations with cough, hemoptysis, and rarely diffuse alveolar hemorrhage, and GI involvement in the form of abdominal pain, diarrhea, and hematochezia. This is, you can see, purpura, and we can guess from the scenario, that is, it is palpable purpura. And this is actually a work on drug-associated vasculitis by Ortiz, San Juan et al. And they have actually made an estimate of presentation of drug-associated vasculitis at the beginning and also cumulative. And we can see here that ultimately skin was involved in 100%, then joints in 51%, GI tract in 38%, kidneys in 35%, and fever was present in 24%. And what are the common offenders? Basic antibiotics, among the antibiotics, cefotaxime, minocycline, anti-thyroid drugs, almost all, anti-rheumatic drugs, sulfasalazine, allopurinol, dipenicillamine, biologic dimers, adalimumab, etanercept, infliximab, psychoactive drugs like clozapine, thyroidazine, and also thiazides, phenytoin, levamisole, hydralazine, retinoids, interferon that we often use. So another group of authors, Doyle, they concluded that therapeutics from nearly every pharmacological class have been incriminated with development of vasculitis. No drug is immune. And what is the spectrum of vasculitis that may be caused by drugs? Here you can see the big list. Cutaneous vasculitis is caused by propylthiouracil, paroxetine, quinine, atenolol. Leukocytoclastic vasculitis by a host of drugs. Then, arterial vasculitis by our methotrexate, procainamide, fluoxetine, a very commonly used antidepressant. Then, polyarteritis nodosa by minocycline and retinoids. Then, eosinophilic granulomatosis with polyangiitis by leukotriene inhibitors and macrolides. IgA vasculitis, propylthiouracil, carbidopa. Then, crescentic glomerulonephritis, the same. So the list is quite big, so I won't go through everything. And propylthiouracil is one of the, I would say, greatest culprit in this regard, because, the incidence of vasculitis is highest with propylthiouracil, and propylthiouracil can also cause a wide range of vasculitis, starting from leukocytoclastic vasculitis to mucocutaneous allergic vasculitis and sensory neural hearing loss. Our anti-rheumatic drugs are also not innocent. We should not forget that methotrexate may cause leukocytoclastic vasculitis and arterial vasculitis. Can someone tell me, what is the other name of arterial vasculitis? There are many rheumatologists here from the, second or third row. What is the other name of arterial vasculitis? Anti-C1q. Thank you very much. Naproxen and ibuprofen can cause leukocytoclastic vasculitis. Allopurinol may cause leukocytoclastic vasculitis, ANCA-associated vasculitis, and CNS vasculitis. And azathioprine can cause, sometimes rarely, intestinal necrotizing vasculitis. In this slide, actually, I have tried to explain how the drugs may cause vasculitis. The drugs may cause vasculitis in two major pathways. The first one is, the drugs may like as heptane, and they may attach with the endothelial surface antigens. And after attachment, this antigen becomes different to the immune system and act like new antigen. They stimulate formation of antibodies, and eventually antigen-antibody complex is formed on the surface of the endothelium. It leads to the vascular injury. That is a simple pathway. We can all conceptualize very easily, because this is something which we read in third year, fourth year. So this is quite simple. But the other thing is possibly not that much simple. And this is also, again, it has been studied mostly with propylthiouracil and also levamisole. And you can see here that propylthiouracil or levamisole or cocaine, they can activate neutrophils. And this activation of neutrophil, in its turn, again activates two different pathways. One is netosis. In this process of netosis, there are neutrophil fragments. Some of them may be rich in PR3 and MPO antigens. They get exposed to the circulation and to the immune system. And also at the same time, these activated neutrophils produce, B cell activating factor, and these B cells are activated under, this net. These B cells are primed to produce ANCAs, anti-PR3 and also anti-MPO antibodies. These are produced, and these ANCAs bind with, endothelial antigens, neutrophilic antigens, and may cause this vasculitis. And there are some additional points. Apoptosis. In the absence of priming, apoptosis is a well-regulated phenomenon, but sometimes it may go somewhat dysregulated. So in the absence of priming is not there, it is associated of translocation of ANCA antigens to the neutrophil surface, thus exposing this, I would say these are sequestered antigens. They are normally not exposed to the immune system. They don't provoke antibody formation, but when they reach the surface of the neutrophils, they provoke antibody formation. These ANCAs in turn are able to bind to the membrane-bound antigens, causing self-perpetuating constitutive activation by cross-linking PR3 or MPO and FCG fragments. And also genetic susceptibility is also important. In genome-wide association studies and also a few exome-wide association studies, a host of genes, have given high-strength signals that they are present in patients with drug-associated vasculitis. So genetic factors are also important. What are the drugs? So I have first told that CHCC, Chapel Hill Consensus Conference, has divided drug-associated vasculitis into two groups. One is drug-associated ANCA-associated vasculitis, and the other is drug-associated immune complex vasculitis. What are the drugs which may cause drug-associated ANCA-associated vasculitis, or DAAAV? Propylthiouracil, methimazole, phenytoin, thiazide, minocycline, allopurinol, our allopurinol, hydralazine, penicillamine, again sulfasalazine, cefotaxime, and retinoids. Rheumatologists are increasing retinoids in increasing frequency. Just we have to remember that we are compelled to use retinoids for various reasons, particularly lupus complications. So here this table I'm showing to highlight the difference between drug-associated ANCA-associated vasculitis and idiopathic ANCA-associated vasculitis. That is also another important issue, because sometimes if a patient comes with vasculitis and if we find that C-ANCA is positive, we tend to put the diagnosis of granulomatosis with polyangiitis. But this is not true. All ANCA positive vasculitis are not ANCA associated vasculitis, you have to remember. So I am showing this example that drugs may cause ANCA associated vasculitis with positive ANCAs, and similarly infections can also produce ANCA positive vasculitis. They are not ANCA associated vasculitis. And this is a study by Alan Wilk, and they included 72 patients who were ANCA positive, and they found that 16 were drug-associated ANCA-associated vasculitis, and 56 had idiopathic ANCA-associated vasculitis. And out of these 56 idiopathic ANCA-associated vasculitis, GPA was present. GPA means granulomatosis with polyangiitis, which was formerly known as Wegener's granulomatosis, in 29, MPA in 23, and EG cutaneous vasculitis was present in 63% in the use group, but in idiopathic group it is 25%, so it was much less common. Renal vasculitis in 19% of the drug-associated group, but 75% in ANCA-associated vasculitis, idiopathic. ANCA spectrum is narrow. You have seen in the lecture of Professor Nighat that in granulomatosis with polyangiitis, C-ANCA is positive or PR3-ANCA is positive. And if you find that P-ANCA is positive in a patient supposed to have, granulomatosis with polyangiitis, there will be deduction of the score. So P-ANCA, the presence of P-ANCA goes against the diagnosis of GPA, and similarly, the presence of C-ANCA goes against the diagnosis of microscopic polyangiitis and EGPA. It means, the ANCA spectrum present in this idiopathic ANCA-associated vasculitis is narrow. It is only either P-ANCA is present or C-ANCA is present. Both P and C-ANCA are almost never occur together in such patients. But in case of drug-associated ANCA-associated vasculitis, ANCA spectrum is broad. You may find P-ANCA, C-ANCA, anti-HLE, and also a few other uncommon types. Then ANA, antihistone, IgM, anticardiolipin, and anti-beta-2-glycoprotein antibodies, they are positive in drug-associated ANCA-associated vasculitis, but they are negative in idiopathic ANCA-associated vasculitis. What does it mean? If you find a patient, who has come with vasculitis, possibly only cutaneous vasculitis, no systemic involvement, and if we find ANCA is positive, both P-ANCA and C-ANCA, or some of the ANCA is positive, but at the same time ANA is positive or anticardiolipin is positive, we should not consider SLE. Rather, we should look for the list of the drugs. Often patients don't tell us the full list of drugs that the patient is taking. Suppose the patient is taking a drug by the advice of some gynecologist or ENT specialist. The patients actually don't feel the importance of disclosing those information to us. So we have to explore. Our responsibility is to explore, to see the full list of the drugs. Serum C4 is often low in drug-induced, but it is normal in idiopathic ANCA-associated vasculitis. Death is quite common. It was in 13 out of 56 patients in this group, but death was completely absent in the drug-associated ANCA-associated vasculitis. Now I should switch to cancer-associated vasculitis. The prevalence is 0.4 to 4.2% of all vasculitis patients harbor neoplasms. But if we go to types, 1 in 1,800 patients with hematological neoplasm develop vasculitis, and 1 in 80,800 patients with solid tumors develop vasculitis. So we can say in both the groups, actually, vasculitis is rare, not common. But in the solid tumor group, it is much rarer. Now, what are the causes of, co-occurrence of vasculitis with neoplasm? One may be chronic inflammation of vasculitis may lead to malignancy. We all know that, chronic inflammation may cause malignancy. Drugs for treating malignancies, for treatment we give drugs, and that drug may cause itself, drug-associated vasculitis, or sometimes that drug causes immunosuppression and cause infection. That infection may cause infection-associated vasculitis rather than that malignancy-associated vasculitis. And the third category is malignancy itself causing the vasculitis. And in that case, only under this third category, we shall call it paraneoplastic vasculitis. And in the next few slides, I shall focus only on paraneoplastic vasculitis. What are the requisites for paraneoplasia? When we can assume that this vasculitis is neoplasm associated. Near simultaneous appearance of both neoplasm and vasculitis, and a parallel course. When the neoplasm is controlled, the vasculitis is also controlled. When neoplasm goes out of control, the vasculitis also comes out of control. So, what is the pathogenesis of malignancy-associated vasculitis? One is, what happened? Yeah, inflammation provoked by neoplasm. So, and because of that, neoplasm may also, elaborate, I would say, antigens on the surface of the cancer cells. And these antigens may act like haptens, as I told about drug, and they can act as haptens, and they may convert our original expressed surface antigens into neoantigens. And also there is chronic stimulation of the immune system, immune complex deposition on the vessel wall, and also development of ANCAs because of this chronic stimulation. This chronic stimulation makes the neutrophils more aggressive, reticulum, endoplasmic reticulum more dynamic, and endoplasmic reticulum becomes confronted with the surface epithelium, surface cell membrane, and the antigens PR3, MPO, all this come to the surface. This is also possible. And production of cytokines. The tumor cells may produce cytokines that render polymorphonucleophils more adhesive. Defective apoptosis. And I say dysregulated apoptosis. And also cancers and vasculitis, also as per genome-wide association studies, it has been shown that there are some antigens which occur more commonly in both cancers and vasculitis. So, they also share genetic susceptibility. So, what are the neoplasms commonly associated with vasculitis? Solid tumors are responsible for 37% and hematological 63%. In a previous slide also I have mentioned that hematologicals are more commonly involved with vasculitis rather than solid tumors. Among the solid tumors, lung, colon, and kidney cancers have been most frequently incriminated. And among the hematological malignancies, myelodysplastic syndrome, particularly chronic myelomonocytic leukemia, is responsible for 33% of the paraneoplastic vasculitis, and lymphoproliferative 29%, and out of them, hairy cell leukemia and non-Hodgkin lymphoma, these are common. What are the types of vasculitis that may occur as paraneoplastic vasculitis? The most common one is the cutaneous leukocytoclastic vasculitis. It occurs in 45%. Then polyarteritis nodosa, 37%. Granulomatosis in polyangiitis, 7%. Microscopic polyangiitis 5%, and IgA vasculitis 5%, and rarely giant cell arteritis and Takashus. Now, I'll show in this slide, which vasculitis commonly occurs in which type of malignancy. Chronic, cytoclastic vasculitis occurs in myelodysplastic syndrome, hairy cell leukemia, and non-Hodgkin lymphoma. PAN occurs in hairy cell leukemia, myelodysplastic syndrome, commonly, chronic myelomonocytic leukemia, and it sometimes present with bilateral perirenal hemorrhage. So whenever a patient presents with bilateral perirenal hemorrhage, we must consider, this PAN, and PAN due to MDS. Non-Hodgkin lymphoma. IgA vasculitis is commonly caused by multiple myeloma, non-Hodgkin lymphoma, solid tumors, particularly renal cell carcinoma. Large vessel vasculitis is commonly associated with myelodysplastic syndromes. What are the pointers to malignancy in a patient presenting with vasculitis? This is the most important thing, that, we should maintain a high index of suspicion. That is true, but there will be certain factors which should raise our index of suspicion to an even higher level. And what are those points? Presentation at an atypical age or gender. For example, we know that, IgA vasculitis commonly occurs in, men or male below the age of 20 years. But if a 55-year-old woman presents with IgA vasculitis like henoxonlin, then we should suspect that dal mein kuch kala hai, and we should search for malignancies. Marked decline in general health, weight loss, remarkable weight loss. Weight loss is also a feature of vasculitis. Failure to respond to conventional therapies, chronic or relapsing course of skin purpura, severe anemia, and very high ESR. It is said that 3-figured ESR, 100 or above. And how we should evaluate when we suspect malignancy in a patient with vasculitis. We should take a very efficient but customized history, elicit constitutional and focal symptoms suggestive of malignancy. I shall show it later. Physical examination including a search for metastasis. It means we should palpate all lymph nodes, liver and spleen very carefully, and also primary palpation of the thyroid, we should not forget, and breast, testis, abdominal lumps, and organomegaly. We should set, very careful palpation as part of general and systemic examination. We should investigate with chest X-ray, abdominal ultrasonography, fecal occult blood test, or carcinoembryonic antigen. Of course, fecal occult blood test, a properly performed fecal occult blood test is, actually more productive than carcinoembryonic antigen. Guided imaging, since, we have palpated vertebral column. So if there is some abnormality, tenderness, gibbous, something like that, we should do, a spinal X-ray also, vertebral column, then CECT of chest and abdomen. Directed endoscopy as per symptoms or signs, and also biopsies. Now, the last part is the infection-associated vasculitis, actually, which I was rather more agreeable to deliver, but I had to make it ultra short. And so common infective causes of infection-associated vasculitis include viruses like hepatitis B virus, C virus, Epstein-Barr virus, cytomegalovirus, parvovirus, varicella zoster virus, Coxsackie virus, and human immunodeficiency virus. Among bacteria, Mycobacterium tuberculosis, Salmonella typhi, Mycoplasma pneumonia, Treponema pallidum, and also a host of others. Protozoa, fungi, parasites, and including nematodes, even nematodes, Ascaris, may also produce vasculitis. What is the spectrum of vasculitis in infection-associated vasculitis? HBV, hepatitis B virus, may produce PAN, leukocytoclastic vasculitis, cryoglobulinemia vasculitis, more commonly type 3, IgA vasculitis, and ANCA-associated vasculitis. Hepatitis C virus may produce, cryoglobulinemia vasculitis, commonly type 2. Aortitis, it may produce also, Takayashu-like aortitis. PAN, polyarteritis nodosa, IgA vasculitis, and leukocytoclastic vasculitis. Parvovirus and cytomegalovirus, both can produce IgA vasculitis and ANCA-associated vasculitis. SARS-CoV-2 may produce ANCA-associated vasculitis. Mycobacterium tuberculosis, aortitis, and leukocytoclastic vasculitis, and Mycoplasma pneumoniae, leukocytoclastic vasculitis, and IgA. Of course, I have shown only very common varieties here because it is not possible to show all the viruses with their full spectrum of vasculitis. What is the pathogenesis of infection-associated vasculitis? Actually, I have picked up hepatitis C because the pathogenesis of vasculitis in association of HCV is the most common, most widely studied variety. It may cause direct invasion of the vessel walls. And what is the proof? Successful remission with antiviral therapy, combination of direct antiviral drugs. There is an hepatitis C virus that is curative. Antiviral therapy indicates that the invasion of the vessel wall was important. The antiviral treatment cures the vasculitis. Autoimmunity, direct interaction between hepatitis C virus infects the B cells, B lymphocyte directly, leading to polyclonal activation and proliferation of B cells producing IgM, including rheumatoid factor. So that is why, this hepatitis C induced vasculitis is associated with, positive RATs, rheumatoid factor. And the reasons may be two. Actually, there are multiple reasons. I am highlighting only two reasons. One is molecular mimicry. That is HCV on the surface of hepatitis C protein, C virus. There is protein NS5A, non-structural 5A protein. It has some, similarity with some endogenous proteins. So there is molecular mimicry, and it may evoke formation of antibodies against those host antigens. And also there is another factor, that is downregulation failure. This CD4, CD25, FOXP3 plus cells are T regulatory cells which can downregulate inflammation due to wide variety of causes. But in hepatitis C infection, it has been found that these FOXP3 positive T regulatory cells are decreased in number in the peripheral blood. So there is some downregulation failure that allow expansion of peripheral autoreactive B cells. And also genetic predisposition, strong signals have been obtained from the loci of HLA DR11, DR4, and DR3. What are the indicators of infectious etiology in a patient presenting with vasculitis? General features of microbial infection: fever with chills, night sweats, polymorphonuclear leukocytosis, and high procalcitonin. Of course, we have to remember all these things may occur in pure primary vasculitis without infection. Also, all these things can occur. But in infection-associated vasculitis, these features are more common. But none of them is specific. Atypical age and sex for the type of vasculitis that I have mentioned, also with malignancy-associated vasculitis. A pattern of vasculitis involving a characteristic organ and an identifiable microorganism. Actually, I am going to that a bit more details just in the next slide. And particular characteristics of an identified type of vasculitis. So you know that this vasculitis has got this spectrum of symptoms and signs. But if it is caused by infection, certain signs and symptoms will be more common if it is due to infection. That also I shall elaborate in the possibly after one slide. This is the pattern of vasculitis with associated infection. There are also quite a large number of examples, but I am showing only 3 examples. One is ischemic stroke following trigeminal zoster, aortic dissection following coronary bypass. They indicate that during this bypass procedure, some microorganism entered there and caused aortitis leading to aortic dissection. Features suggestive of renal, CNS, or pulmonary vasculitis in course of Rocky Mountain spotted fever. What are the indicators of infective etiology in an identified vasculitis that I mentioned in the last line. So in case of, hepatitis B associated PAN, polyarteritis nodosa, the onset is abrupt. It usually occurs in patients younger than 40. Idiopathic PAN more commonly occurs in patients above the age of 40. And constitutional features like fever, chills, night sweats, anorexia, weight loss, and myalgia, they are more common in HBV-associated PAN than compared to idiopathic PAN. Similarly, HCV associated with cryoglobulinemia vasculitis. Sicca symptoms and painful leg ulcers are more common in HCV cryoglobulinemia vasculitis compared to other types of cryoglobulinemia vasculitis, and particularly Sicca symptoms is very much important because Sicca symptoms are not found in cryoglobulinemia vasculitis. In causes other than hepatitis C. Go to the general principles of organism identification, and then I shall go to organism identification in specific types of vasculitis. And there also I shall give only 3 examples. Now I shall not go to all the, because that will take 2 hours. What are the general principles of organism identification, like sputum, exudates from ulcers, etc. Cultures, detection of microbial antigens like HBsAg or HBeAg when you suspect hepatitis B infection, detection of antimicrobial antibodies, that is also one of the principles of microbiological diagnosis, IgM antimycoplasma antibody, anti-HCV antibody. These we commonly resort to. Detection of viral particles or intact virions, and immunohistochemistry of tissue specimens. For example, actually, this was an example. I just showing the example here. In some patients with cerebral vasculitis, cerebral brain biopsy revealed the presence of Bartonella henselae. Now, about culture, I must say something about culture. When vasculitis is caused by direct vessel wall invasion by the microorganism, by the bacteria, then the cultures becomes positive in 50% of cases, for bacteria and also fungus. And also, we should send for culture other appropriately selected specimens like sputum, urine, exudates or swab from ulcers, bully, urethral exudate, and biopsy specimens. Sometimes, we can send biopsy specimens like skin biopsy specimen, vessel biopsy specimen also for culture. But we have to remember here, particularly in our country, prescribing an antibiotic is a very common practice. And we can rarely find a prescription in which no antibiotic is present. So never prescribe antibiotics before sending appropriate specimens for culture and sensitivity if you suspect infection-associated vasculitis, or even if you suspect any infection, I should say. Now we should come to detection of, microbial particles or intact virions, where we go for microbial particles. PCR for microbial nucleotide, we carry on this, like hepatitis B viral DNA, HCV RNA, Coxsackie viruses, varicella zoster virus, and Bartonella. And varicella zoster virus antigens and varicella zoster viral DNA both have been detected in temporal artery biopsy specimens in patients with giant cell arteritis. So if a patient presents with giant cell arteritis, but the age and gender, giant cell arteritis is more common above the age of 60 and more common in women. So if a 45-year-old man presents with features of giant cell arteritis, we should suspect infection, and in that case, we should take a biopsy specimen. Actually, we can do varicella zoster investigate without invasive procedure. But if we do temporal biopsy, we should do the biopsy for, we should examine the biopsy specimen for varicella zoster virus antigen and DNA. Now I am going to organism identification in specific types of vasculitis. Leukocytic cystic vasculitis. Actually, I didn't go to details of which organisms cause which type of vasculitis. That is also possible. There may be one complete lecture on that issue only. And when we should suspect infection in a patient with leukocytic cystic vasculitis, when the patient also has fever. Usually, patients with leukocytic cystic vasculitis don't have any fever. But if they have fever, chills, night sweats, and polymorphonuclear leukocytosis, we should do these investigations: serum procalcitonin, gramestin of exudates, HBsAg, and hepatitis B viral DNA. Then, CS of exudates bloods, like particularly for Aerococcus, Listeria, and Burkholderia, IgM antimycoplasma antibody, anti-cytomegalovirus antibodies, either IgM or fourfold rise of IgG, and PCR for Uroplasma urolyticum DNA. When we suspect infection in a patient presenting with features of IgA vasculitis, what investigation we should do? One is IgM antimycoplasma antibody. I have shown earlier that mycoplasma may cause IgA vasculitis, and PCR for Epstein-Barr viral DNA in blood or plasma. And if the patient also has loose motion, sometimes it happens. Actually, I also got two or three patients in my lifetime that those patients had diarrhea, prolonged diarrhea after taking some antibiotic. That is antibiotic-associated diarrhea. At that time, Clostridium difficile toxins were not identifiable in Dhaka city, but this Clostridium difficile may cause IgA vasculitis. So if the patient has diarrhea, we should also send fecal specimen for Clostridium difficile toxins A and B. When we find fever in a patient with aortitis, particularly if with atypical features like male gender or age more than 40 years, Takayasu commonly occurs, before 40. If chills are present, if the typical features of autoimmunity that are often present in patients with Takayasu, like arthritis, are absent, then also you should suspect infective etiology. And if the patient has got polymorphonuclear leukocytosis and high procalcitonin, then we should suspect, in infection-associated aortitis, and in that case, we should send blood culture for Staph aureus, Streptococcus pneumoniae, and Salmonella. And also, we should do tuberculin test and contrast-enhanced CT scan of chest and TPHA, Treponema pallidum. So, what we should do in Bangladesh, particularly in the situation of Bangladesh, we should carry out a focused history and examination that should be customized but thorough, very efficient. Routine urinalysis, complete blood counts, X-ray chest PA view, study of stained smears and culture, and that may include swabs from ulcers, exudates, fluid from blisters and bullae, serum ALT creatinine, procalcitonin, and HBsAg. This should be considered as routine in patients with vasculitis in our country, particularly if the patient has got some feature suggestive of infection. So my take home is vasculitis are commonly caused by autoimmunity. Immunosuppressive therapy is quite, I would say quite sensibly the first choice of treatment. Drugs are common. Infections and cancers are not common, but merits early identification. Drugs also merit early identification because it is quite pointless if we start treating a drug-associated vasculitis patient with steroid and other immunosuppressive drugs. It will be a great folly. So earlier, owing to differences in treatment and outcomes of delay in treatment, so we have to be cautious. Treatment of infection-associated vasculitis with immunosuppressive agents alone may lead to proliferation of the causal microbe with further organ invasion and damage and sometimes even death. And maintaining a high index of suspicion and a thorough clinical evaluation, including focus search, are unescapable. We cannot escape this. So, next month, our Padda Bridge is going to be opened with opening a new era in the history of Bangladesh. I thank you all. Thank you. চেয়ারপারসন জিজ্ঞেস টাইম আছে কিনা একটা ব্যাপার আছে টাইমে কনস্ট্যান্ট থাকতে পারে
I want to see. You can say. Huh?
Due to time, only one question there are.
Sir, with your kind permission.
Sir, thank you very much for your excellent speech. I am very much confident that all of us present here will be benefited from your speech. Due to time constraint, only 2 questions will be allowed. If you have any question, please raise your hand.
Rafia.
I want to see.
Okay, please stand up. Okay. Shoel, Mainuddin Shoel.
Thank you, sir, for your nice and informative presentation. I had a question. I have a question that is, in infection list, we have shown many infectious disease may associate with vasculitis. I just want to know the thoughts about vasculitis associated with COVID-19 infection, and what if it occurs, what might be the management plan?
Okay, thank you very much. In fact, vasculitis occurs rarely, and I have shown that COVID-19 may cause vasculitis, particularly when it is severe. But COVID-19 more often produce vasculitis mimics, like chill brain is a vasculitis mimic, and also Kawasaki-like presentation. These are Kawasaki-like presentation. Of course, it is true vasculitis. They may occur. And when they occur, actually, I think there is no randomized support of randomized control trials regarding treatment of COVID vasculitis. COVID vasculitis in mild to moderate cases subsides spontaneously. But if this is severe, in that case, we have to treat it as the original type of vasculitis. If it is, for example, Kawasaki, we have to treat with IVIG. Like the original vasculitis, yeah. I think you were going to ask, or I think you should allow her or comment.
Thank you, sir, for your very elaborative and informative speech on this vasculitis induced by infection, malignancy, as well as drugs. You have enlightened us with explaining all the secrets of vasculitis, especially with a host of drugs, plus all these very, very important infections which may surface when we get a patient with vasculitis with the palpable purpura. The patient comes with to us with a negligible arthralgia, palpable purpura, and on investigation we find that infective causes are behind that, which you have very elaborately explained. And also very important one was a malignancy, which you have explained that the solid tumors as well as hematological malignancies which has been surfaced on investigating this vasculitis. One interesting question came to my mind. You have given the advice to the Bangladesh, all physicians of Bangladesh, that from the rheumatological point of view, what are the basic investigations you have to do if you get a vasculitis patient. But sir, my humble question is, will you advise for skin biopsy if you get a patient with palpable purpura who comes to you? Will you advise for skin biopsy in the basic investigations?
Yeah, actually, and in fact, that is another chapter. In fact, I didn't go into details of that. First, in patients, if we suspect infection-associated vasculitis, first we have to confirm the presence of vasculitis, and then we should go for infection. Actually, if we classify like this, basically we have to do everything simultaneously and very quickly. We cannot go step by step for this, but we have to establish the vasculitis. just because of brevity, shortage of time, I was given half an hour, shortage of time, I didn't go into how to establish the diagnosis of vasculitis. For establishing the diagnosis of vasculitis, you know, the skin biopsy is very much important in patients presenting with cutaneous vasculitis, very important. But if we go for, you know, identifying, you know, the causal microorganism, you know, responsible for that cutaneous vasculitis, in that case, biopsy can help us sometimes by showing the organism, and sometimes also we may send culture, we can do smear examination. In these processes, the biopsy specimens will help us, but also there are other means for, you know, reaching the microbial diagnosis. Actually, I intentionally avoided establishment of the presence of vasculitis.
Thank you.
Welcome.
Sir, can I have a question, please, sir?
Okay, thank you.
So important, I will be asking questions on the part of vasculitis and malignancy. Because when you're saying that vasculitis is a part of malignancy or is a risk factor, then I would say that it needs a very important case control studies. Now, the problem is that malignancy usually is diagnosed in hospital and when the control is taken from the population. So when the population-based control taken up and the diagnosis came up, it becomes a total biasness. So do you think this impression of vasculitis and malignancy is always an interlink? Because sometimes they say that vasculitis can develop 15 years before that malignancy. Then how come the malignancy can be, sir, you know, just a link up? Can you say something, highlight on that point?
Yeah, that's true. In fact, you know, this is sometimes very difficult to establish, and, you know, the studies that I have shown, in fact, they have confirmed the etiological association, and they have compared the different groups with this. In our practical field, sometimes, you know, we will be failed to establish whether it was the cause or it was the result. Definitely, it will remain difficult. And in fact, we are lucky that if a patient has got malignancy, the treatment of the malignancy becomes the top priority. You know, even, you know, we may sometimes forego the case of vasculitis, and the antineoplastic drugs may also control the immune-mediated vasculitis because they suppress immunity at the same time. So, you know, actually, though it will be difficult for us to establish, to confirm the nature of the association, the treatment possibly will not fail.
Thank you, sir. Now it's time for comment from co-chairs. I would, due to time constraint, I would like to request our co-chairs to make brief comment. First, from our foreign delegate, Professor Sarbani Senshan Gupta, then Professor Dr. Robed Amin, Line Director of Non-Communicable Disease Control Program of Director General of Health Services of Bangladesh.
Thank you. At the outset, I must sincerely thank the Bangladesh Rheumatological Society for inviting us to attend this 14th International Scientific Conference. All over from India, we have come, the rheumatologists from Indian Rheumatological Association have come to attend this program, this prestigious program on invitation. And I must thank sincerely our Professor Syed Atikul sir and Professor Minaj Rahim Chaudhuri, Professor Nazrul Islam, and all other teams and scientific committee of this 14th International Conference on behalf of our West Bengal chapter of Indian Rheumatological Association. We have been enlightened, and we have a great experience on attending this program here in Dhaka, and we have seen how progression has been made. We have learned yesterday and today that how progression in the medical history of Bangladesh is. We are really amazed to see this progression. And especially this Rheumatological Association with an international figure like Professor Atikul sir and other rheumatologists from Bangladesh. We are really grateful to come here and have your associations here. And now from this session, I must sincerely say that it was an amazing, amazing lecture given, delivered by Professor Syed Atikul sir. And we had learned a lot of secrets of vasculitis from this lecture and the previous lectures too. And we have also listened to this ultrasound diagnosis of great arteries, giant cell arteritis and autoarteritis. That was an excellent lecture by Professor Minhaj sir. And it is really a great experience for us. And I must say, and I must thank you, this Bangladesh Society, Rheumatological Society. Thank you.
Thank you very much. First of all, the Bangladesh Society, I mean the Rheumatology Society, for bringing me in as the chairperson, and thank you very much, Ramani, to become the co-chair as well. First of all, what I like to say is that when a person becomes more than an industry or institute, he is to be praised up. That was an absolutely stunning presentation from Syed Atikul Haq sir. I say that as because you see there will be always some people who is great to look, there will be always people who is great to watch, and there will be always some people who is great to listen. But when a people becomes great to watch, listen, and also look, then it becomes supposed to say that article. Thank you. So possibly this is one of the stunning presentation of the part of vasculitis. It's a very difficult, I would say, a complicated topic. It's not easy because there are three issues. One is the drugs, another the infection, and there's the malignancy, and then linking up with the vasculitis. Or do we have to linking up the vasculitis or the consequence or association? There are huge perspective, and he has been done it a very nice way, lucid way. And so the rheumatologists of our country, and especially the students, I would say the undergrad and postgrad had extremely benefited through this wonderful lecture. And I personally came up to be highly benefited as a student of Professor Syed Atikul Haq. I would have very simple get from his lecture. One is thing that drugs is a very common issue of the vasculitis, and any drug can cause vasculitis. So this is the very principle that he has said. And also, as because the drugs can lead to many of the haptens, it can stimulate many of the intracellular organelles. So you can expect to have many positive autoantibodies. That has been the highlighting points. Malignancy, we came up to know that the solid organ malignancy is less likely to have a vasculitis rather than hematological. Another important pointer from his lecture is that small vessel is more common in malignancy rather than the large vessel vasculitis. And infection is a huge issue. He has covered it very nicely. There was one chapter on the part of the COVID-19 and the vasculitis in the Lancet, which actually shows that there are vasculitic as well as vasculitic mimickers of the Kawasaki and others in patients with histopathologically confirmed vasculitic syndrome in COVID-19 as well. So he also mentioned it very nicely. A N type as well as in cutaneous vasculitis type is there. So a lot to learn, and it was amazing actually learn from the very respectable teacher from Syed Atikul Haq. It was a great honor actually to have him as a chair. Thank you very much for bringing me in.
Thank you, Professor Robed Amin. Actually, everybody we knows Professor Hawk's lecture is full of information and intellectual touch in every slide. And a pin drop silence of this august gathering again proved that Professor Syed Atikul Haq is unparalleled speaker. So please give a big clap for Professor Syed Atikul Haq. Thank you, chairpersons, dear moderator. Now, I'd like to request Professor Minhaj Rohim Chaudhuri sir to come up on the dais to hand over memento to our speaker, chairpersons, and moderator. First to our foreign delegate, Next, Professor Robed Amin. He's the director, NCDC, and he's always smiling, a smiling face. Professor Robed Amin. Okay, Chairperson, Dr. Sarbani Sengupta. এবার তুমি থাকো আমি moderator. ওকে স্যার ভালো হয়েছে লেকচার সুন্দর হয়েছে স্যার বসেন
আচ্ছা ঠিক আছে
Now this is most important part, raffle draw, lottery, especially like me, those who believe arts, not science. This is important for me, people like me who believe arts. So we have, before that, I have to announce one result, poster presentation. Our jury board selected 3 poster. First, second, third. First, Dr. Taskia Haq. Second, Dr. Monirujjaman. Third, Dr. Shaista Ali Khan. Now, we are going to start our raffle draw session. I like to declare another prize, 3 prize. That was a live quiz done by Healthcare Pharmaceuticals with 3 attractive prize: iPhone, 3M Littman Classic 3 stethoscope, and earbud. First prize owner, Dr. Imam Gajjali. iPhone 13, Dr. Imam Gajjali. Not here, Imam Gajjali, not here. Okay, come. Hey, prize koi? একটু অপেক্ষা করো সামনে। সেকেন্ড প্রাইজ ওনার মোহাম্মদ জিয়াউল হায়দার। All are rheumatology alumnis. Third owner, Mohammad Kamrul Hassan Shojib. আইফোন গুলো কই, ওদের প্রাইস গুলো কই? আচ্ছা আপনাদেরগুলো এখনই দিয়ে দেবো, শুরু করুন। ওটা তো পেয়ে যাবেন ওখানে, হার্ড কপি। Actually, we don't have enough time. Now I like to request Dr. Sabrina Yasmin. Now I like to request Professor Soed Atikul Haq sir, Professor Nazrul Islam sir, Professor Minhaj Rohim Choudhury sir. Please come upon the dais and hand over three valuable, most valuable prize to hand over to our lucky winner, Dr. Gadjali, Dr. Jia, and Dr. Shojib. বুঝে নেই অনেকে কখন হয়ে গেছে।
Also won a prize last time for laptop, I remember. Gadjali to namer iye ta rakhche dekha
গাজ্জালি নিবে বিআরএস এর প্রেসিডেন্টের হাত থেকে। এবার সজীব কই? জিয়াউল হায়দার, সেক্রেটারি জিয়াউল হায়দার। কোন স্বজন প্রীতি হয়নি স্যার এখানে, রিমাটোলজিস্টটা পেয়েছে। আর থার্ড প্রাইজ ভাইস প্রেসিডেন্ট প্রফেসর নজরুল ইসলাম স্যার। স্যার উল্টা পাল্টা হলে তো আপনাকেই দিতাম, কারণ ওদের চেয়ে আমি আপনাকে বেশি পছন্দ করি। একটা মোবাইল পাওয়া গেছে, খুব দামি মোবাইল। যদি কেউ মালিক পাওয়া যায় তাহলে 2 কেজি মিষ্টি সহ এখানে চলে আসেন। আচ্ছা আমি লটারি টোকেনটা উঠানোর জন্য একজন নিরপেক্ষ, বয়স 7-8 কম হলে ভালো হয়। ফয়জুন্নেসা মুন্নি, আপনার মেয়ের বয়স কত? 7-8 কম হবে না বেশি? অর্ধেক? তাহলে তো আরো ভালো, নিয়ে আসি। এটা উঠাইতে হবে তো এখানে। ডক্টর সাবরিনা, আপনাকে একটু কষ্ট করে একটু স্টেজে আসলে ভালো হয়। আপনি আসেন, আপনি গতকালকে খুব ভালো পারফর্ম করেছেন, আসেন। মোবাইল
মাস্ক
নাম্বারটা আসছে 15 নম্বর রেফেল ড্রপ অলরেডি উঠানো হয়ে গেছে। এটা এসকেফের রেফেল ড্র, বেশ কয়েকটা রেফেল ড্র আজকে ছিল। এটা এসকেফের ইসোরাল এবং টোজাকের সৌজন্য রেফেল ড্র। না আপনি দিয়ে ওর কাছে দিয়ে যান, আমরা উঠে ফেলবো। আপনি যদি ইয়ে করতে চান তাহলে আমি আপনাকে ডাকবো। আচ্ছা জি, আপনি যদি কথা বলতে চাইলে ডাকবো, ওই যে ওর কাছে দেন। উনি কি ডক্টর ইয়ে করবে, কন্টাক্ট করবে? ঠিক আছে।
আচ্ছা কি সাউন্ড হচ্ছে নাকি হচ্ছে না?
আপনি থাকেন।
হ্যালো শোনা যাচ্ছে? সাউন্ড হচ্ছে না? হচ্ছে। এটা কি 15th? আচ্ছা, 15তম পুরস্কার। আমি বুঝে গেছি যে আজকেও আমার কপালে কোনো পুরস্কার নাই, সেই জন্য শাহিন ভাই আমাকে এই যে স্টেজে তুলে নিয়ে আসছে। তো এই দুঃখ ভারাক্রান্ত হৃদয় নিয়ে আমরা আজকে আবার র্যাফেল ড্রটা করি। 15th পুরস্কার, সিরিয়াল নাম্বার 0। এই গতকালকের মতো আবার কিন্তু 0 শুরু হয়ে গেছে, তবে সেই 0 প্রথমে না, শেষে। লাস্টে 0, আগেও 0। প্রথম অক্ষরটা কত হবে? কত কত জোরে বলেন? 300 কে আছেন? ও ইয়েস, পাওয়া গেছে। চলে আসেন। 300 চলে আসেন, তাড়াতাড়ি চলে আসেন।
এই 15তম প্রাইজটি দেওয়ার জন্য আমি এবার ফার্স্ট হলো কে? ডাক্তার গাজ্জালি। গাজ্জালিকে ডাকছি। গাজ্জালি, তুমি চলে আসো স্টেজে।
গাজ্জালি পুরস্কার নিয়ে যে আবার পুরস্কার দিচ্ছে।
গাজ্জালির কপালের সাথে অন্যদের কপাল একটু আসো গাজ্জালি।
গাজ্জালি কেন দাঁড়াও,
উঠায় ফেলো। সেকেন্ড উঠায় ফেলো।
আপনার পরিচয়টা?
ডক্টর মোহাম্মদ মামুনুর রহমান। ডক্টর মোহাম্মদ মামুনুর রহমান, বিএসএম পালমোলজি।
না ঠিক আছে, অসুবিধা নেই। তুমি উঠাবা, আরেকটা উঠায় ফেলো। হ্যাঁ, সময় নেই তো।
দেখি ছানা উঠাও তো দেখি।
হ্যাঁ হ্যাঁ, ওটা তো আমরা তুলে ফেলবো, সময় নেই আমাদের।
তুলে ফেলো দেখি তোমার
কোনটা নাম উঠেছে?
ওকে, 14th প্রাইজ। থ্যাংক ইউ। এবার 3 প্রথমে, 9 সবার শেষে। 3, 9 এর মাঝখানে কত হবে? 7, 3, 4, 3, 5, 9।
359।
ইয়েস, পাওয়া গেছে।
14তম প্রাইজটি দেওয়ার জন্য আমি ডাক্তার সাদিকুল ইসলাম সাদিক ভাইকে আসার জন্য অনুরোধ করছি। সাদিক ভাই প্লিজ। আমরা সবাইকে আমাদের যারা আপনি ওটা বুঝবেন।
আপনি প্লিজ আপনার পরিচয়টি দিন, তার আগে কাগজটি দিন।
অ্যাকর্ডিং টু আতিক স্যার।
আমি ডাক্তার মোহাম্মদ তানভীর হাসান, এমডি রেসিডেন্ট ফেজ হেড নেফ্রোলজি, ঢাকা মেডিকেল কলেজ।
থ্যাংক ইউ সাদিক ভাই। তুলে ফেলো, তুলে ফেলো দেখি এটা দেখি। ও ইয়েস, পাওয়া গেছে। এটা হচ্ছে 13তম। 13 কিন্তু আনলাকি না, লাকি 13। 262
বগি।
সুলেমান
রাজন।
আজকে সব আছে।
সুলেমান রাজন। এই জন্য আমি ডাক্তার আরিফুল ইসলাম, অ্যাসিস্ট্যান্ট প্রফেসর, প্লিজ।
রাজন কি পারবে এটা নিতে? আচ্ছা, আমি আরেকটা তুলে ফেল, এটা বাক্সই বড়। ওকে, ঠিক আছে। এত বড় gift, রাজন, এটা গিফটটা স্যার বলছি মনে হচ্ছে মাইক্রোওভেন, তো সেই জন্য রাজন বললাম যে ও উঁচু করতে পারছে কি
পিওরেট ক্লাসিক।
পিউরেট পিউরেট, ঠিক আছে, সবাইকে পানি খাইয়ে দিবে, অসুবিধা নাই, তুমি তুলে ফেলো।
এসকেপ বুঝতে পেরেছে ওয়াশার পানির অবস্থা খারাপ।
ইয়েস, 12তম, 12তমতে 12 আছে,
কুকার
12তমতে 12 আছে, কিন্তু 12-র আগে আবার একটা সংখ্যা আছে, সেটা কি? কার কার 12 আছে? আছে কারো? 412, 412, 412, আমারটা মিলিয়ে প্লিজ। 4121, 4122 and 4123. Boogie. Cancel.
দিয়ে দাও দিয়ে দাও।
তুলো 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 তাড়াতাড়ি।
তুলো তুলো তুলো।
কি আমরা তোমারটা পাই কিনা? এবার 12তমতে কিন্তু 12 নেই, তবে 2 আছে। 2 267, 267. Yes.
রাইস কুকার 12তম রাইস কুকার। এই প্রাইসটি দেওয়ার জন্য আমি একটা জাহিদ আমিন, ডক্টর জাহিদ আমিন প্লিজ।
কি এটা?
12তম রাইস কুকার।
ও ইটস রাইস কুকার।
জাহিদ আমিন মনে হয় এটা লাগবে না। লাগবে জাহিদ আমিন তোমার এটা?
না, এটা জাহিদ আমিন পুরস্কার তো।
ও তোমার ওয়াইফের জন্য।
জাহিদ আমিন দিবে।
ও দিবে?
হ্যাঁ, দেখি। ইয়েস, ঠিক আছে। খুবই দরকারি জিনিস।
11th
দেখি, আচ্ছা। এটা দেখি, তুলে ফেলেন। এই তো 11তম, 11th, 3,
হ্যাঁ 11তম
11তম পুরস্কারের প্রথম হচ্ছে 3, লাস্ট হচ্ছে 6, 36, এর মাঝখানে
প্যানাসোনিক মিক্সার গ্রাইন্ডার।
মাঝখানে একটা আছে 3 এবং 6 এর মাঝে কি 3 আর 5 কারো আছে? 306, এই পাওয়া গেছে, একজনই পাচ্ছে নাকি? 306। এবার তো ভুগি হচ্ছে না বেশি।
এটা আমি ডাক্তার মামুন, হসপিটাল আব্দুল্লাহ মামুন চলেছেন।
ডক্টর আসিফ প্রেসিডেন্ট
ডক্টর আসিফ কিন্তু শিওর ছিল যে উনি পুরস্কার পাবেন। উনি আমার দোস্ত কপি করে নিয়ে এসেছে। উপরে 10, না? হ্যাঁ, দেখি। এটা উপরে রাখেন, ওটা সুবিধা হয়। তুলে ফেলো। দেখি দেখি না। যেকোনো একটা ধরো। ভাগ্য যার সহায়, তাকে কোনোভাবেই ফেলা যাবে না।
ধরে পরিশ্রম করলাম।
1, 2, 3, 1, 2, 3, 1, 2, 4,
SMS.
তো